Welcome to another episode of the Golden Hour. I'm Sharif Yunus here with Dr. Kevin Majors. Kevin, I'm excited to be here with you today to discuss a pretty big topic.
Yeah, Sharif, I'm looking forward to this.
Well, Kevin, as you know, our approach is very centered on behavior as part of CBT. But as a psychiatrist, you also have work with medicine. So I wanted to kind of examine the link between these two things. You know, medicines are used to treat standard psychological conditions like depression, anxiety, ADHD, all of which are related to things that we aim to help people with. So maybe we can go through these one by one and start to understand the role of medicine versus the role of behavior and when one or the other is appropriate. So, Kevin, is there a particular medicine that kind of jumps out at to you for any particular reason? Maybe it's one you have to work with a lot or one you don't like working with.
I think the kind of medicines that I have the biggest issue with are medicines that get rid of anxiety by putting your amygdala to sleep. So those are medicines like Xanax, Klonopin, Valium. So there are these, they're called benzodiazepines. So benzodiazepines, in my mind, make it, they just reinforce in people's minds, when they take them. Because what happens is people get anxious and then they're like, oh, I need to take a pill. And then they'll take the Xanax or the Klonopin, whatever, and their anxiety just goes away and they feel great. But what's happened is now there's no new learning they can do because they put their amygdala to sleep. So now they can't train it. And in fact, right before they put to sleep, they were training it with the medicine to see the anxiety itself as a threat to be avoided. So as long as you're taking a medicine to prevent a normal emotion, you'll never be able to shape that emotion. So in my practice, my ability to prescribe is a little bit helpful sometimes to help get people off of those medicines. So now there can be occasionally a use for it, you know, but I think that for the most part, it's like it's taking a step backwards, and it makes it harder to take steps forward. So that's the medicine. Like, okay, is I have a general rule of generally I don't prescribe those, and instead I help people to welcome the normal emotion of anxiety and to whenever their alarm is sounding, to do the kind of behaviors that retrain it so that it's easier next time, and then it's easier the next time, and it's easier the next time. So you want that virtuous cycle of learning, which the medicine, unfortunately, that kind of medicine totally thwarts it.
Yeah, it gets to your idea that when you suffer from anxiety, it's not some malfunction of your brain, but actually it's your brain working properly. It's responding to the training that you've given it. So
Exactly. There's
there's no
nothing
need for a
broken.
yeah.
Yeah. Anxiety is not an illness. It's a normal emotion that is just a result of training, and it is always workable with training.
Mhm.
I also
So
just
and
remember that
yeah, go
I
ahead.
remember this case of like where I actually did use Klonopin, I believe it was, in a person who hadn't taken it before.
So
And it
what does
was
that
a
do?
guy who, so it just means that he had never been used to it and he wasn't asking for it, but he was extremely nervous about his upcoming wedding. Okay. And then so he was he's saying, like, there's not that many ways I have to practice it. So what do you do? And so you can't really get the crowd all there. You can't have, and we didn't really have that much time to work in therapy because there are definitely ways we could have gotten him there. And because of the shortness of time, I said, here, and I gave him it was like a 0.5 milligram of Klonopin. I said, test it one day. And then if it is okay, then you can take it the morning of the wedding. And he took it and it was great. And he never wanted to take it again. And I only gave him a few. And so in my mind, that is like an okay use of it. Uh, but then I had another case where we had just a little bit more time to work, and it was a young woman getting married, and she was incredibly nervous about the wedding, but she didn't want any medicine for it, and instead, it is essentially one session talking about it, And I said, look, what's going to happen is you're going to have all this adrenaline, which is previously what you experienced as anxiety. But adrenaline actually brightens your eyes. It makes it easier to smile and connect to people. It actually makes you radiant. So why not, when you experience that, the adrenaline coming, just radiate it and look at the people in the crowd, all the people who love you, and just give them the smile and shine. She loved that idea, and she had a fantastic wedding day, and it went really well. She felt great about it. She was beaming, and I think she had a better experience because she learned something about adrenaline and anxiety. You don't have to prevent it. You don't have to make it go away. I think so. I think she actually got more out of that whole experience. No, they both got married. That's great. But one of them didn't learn these deep lessons. This is just like, he, in his mind, disaster averted. But with her, it was like, wow, this is a new way of living. And that's what I want people to have.
That's great. I mean, is there something here where treating symptoms versus causes? I don't want to paint with too broad a brush here, but it seems like with the medicine, you're getting rid of a symptom, whereas by completely reframing your view of the anxiety, you're getting to the root cause.
Yeah, that could be one way of seeing it. I think that it's also that the cause of, a person's um, negative experience of anxiety is that they view it as a disorder. And so giving a medicine to make it go away is just confirming in their mind that this is a disorder. Uh, the the symptoms are just the normal body's response working as it should given the state of training. And so you're taking something normal and actually getting rid of it. And so, yeah, you are, by trying to treat the symptom, you're actually treating the thing that's normal, and you're reinforcing the idea it's a disorder. So it's just totally backwards. It's much better just to say, wait, there's nothing disordered happening in anxiety. It's uncomfortable, yes, but it's actually the efforts to suppress it and get rid of it that really lead to the disability of anxiety. Anxiety can be, when you're fighting it, it can be incredibly painful and constricting. And so that, not to minimize that at all, because it can be an enormous trial. But flipping your view of it and learning to practice bit by bit and gain confidence in a new approach, so you're relating in a new way to adrenaline, is incredibly liberating. And I've gotten to see just hundreds and hundreds of people get liberated from that.
So you mentioned one very valid use of these medications for anxiety, which is a kind of one-off event. Although you pointed out that there are probably better ways to deal with that in the case of the young woman at the wedding. Are there other? What are the other kind of valid ways of using the anxiety medication? I mean, for one, if you're trying to retrain, so the in uh, in overcoming anxiety, you want to retrain your amygdala so it doesn't perceive things as threats that are no longer threats. So turning off your amygdala, I can see as counterproductive. Is there a sense in which you want to like at least lower the kind of activity of it or lower the threat level so it makes it easier to deal with, so you can kind of get a better hold on it and then start with the behavior training?
So, unfortunately, taking the class of medicines I mentioned, the benzos, taking that seems to really interfere with safety learning because the amygdala is kind of put to sleep. It You can't do exposure therapy, and at least that's the traditional view inside the field. I'm not sure of the data on that, but it does seem to make sense to me. I think that there are medicines like SSRIs, things like Zoloft, Prozac, Paxil, Lexapro, uh, that that make your amygdala less likely to fire, and those do not interfere with safety learning at all. So it could be that if someone's on one of those kinds of medicines, you can do all the regular therapy like normal, and all the training works just fine. And then once they're better and they've flipped their view of whatever the triggers are, and now those things bring out the best in them, then you can start very slowly going down on those medicines. But you have to go down very slowly, and that's a key thing. So uh,
Well, maybe we could now shift gears from the anxiety medication to antidepressants to start thinking, well, how do those work? I can
yeah.
see
And no,
very
that's
clearly.
exactly what
Yeah.
we've been mentioned. I just mentioned the SSRIs, which are the prototypical antidepressants.
Oh, okay.
So they
Gotcha.
have like an anti-anxiety effect, but they also have an antidepressant effect.
I see.
Um, And I think antidepressants are there's just it's a fascinating area right now in psychiatry, trying to understand the data supporting them. So there's a guy here at Harvard. He's the associate director of the placebo studies program, Irving Kirsch, who actually trained one of the main people who trained me when I was in training. So he's like a mentoring grandfather to me. And Irving Kirsch has a book called The Emperor's New Drugs, where he's making this claim that antidepressants are placebos. They're enhanced placebos, he says, because they cause side effects. So when you're taking them in a trial, you know you're getting something active. And so, because there's side effects, there's more side effects. And so, in fact, he makes the claim that that explains the benefit that you get from them. So it's a very compelling argument, to say that really what's going on with antidepressants is just an enhanced placebo effect. Uh, and the difference between placebo and antidepressants is very small, not enough to be clinically significant. Okay, so this caused a lot of thinking, I think, in psychiatry. But in the things that people wrote to support or challenge it, um, I think that there's a deeper point that kind of got missed. I have my own take on this argument. Uh, for the record, I don't think antidepressants are placebos. So, but I think that they work the same way placebos work. Okay, so it's hard to separate them, but okay, the way this gets a little into what is a placebo. So, a placebo is simply something that causes a specific benefit because of a specific positive expectation. So, you take a placebo pain med because your knee is hurting, and then voila, there's a big placebo effect for pain meds. In 15 minutes, your knee isn't hurting anymore. So, well, it's actually the power of expectation. And even if you look at the scans, the brain scans of people, their actual pain signal in their brain has gone down exactly as it would have if they'd taken the real med. So placebo effects are real, and but they're specific to conditions that are sensitive to expectations. Okay, now depression then is a very particularly interesting thing to study with regard to the placebo effect, because in a way, depression is a disorder of negative expectations. They're just at baseline expecting bad things. And this is what's due to what's called the negative processing bias. So, the negative processing bias means your brain has gotten really strong muscles of detecting negatively charged things in your environment and bringing them to your attention. So, you're just really good at selectively noticing negative things or negative possible interpretations of maybe more neutral things. Well, okay, so when you give someone a placebo that works as a placebo and they're depressed, it works because they're expecting to get better. Well, if you have a disorder of negative expectations, just expecting things to always be getting bad and worse, and now you're expecting it to get better because you're taking this pill, you in fact start to feel better. But that in fact is treating the illness. The illness is negative expectations. And the antidepressants also do that. So a large part of their effect is because of positive expectations. But the thing that gets missed in a lot of these debates is that is exactly the treatment for depression, is to help the person now have the positive expectations. Antidepressants do a little bit more. And I don't think it's because of side effects, that people know they're taking the active drugs, so they expect it even more. I think it's because antidepressants reverse the negative processing bias so that temporarily, when you're taking the antidepressant, your ability to notice positive things comes back. The super efficient noticing negative things goes back down. So you get a more balanced ability to notice things. Well, and then that has a huge impact on your ability to expect things because your brain is always making predictions. What am I going to get? What do I need to do? With a negative processing bias, all of those predictions turn negative, and that's what causes depression. So, because antidepressants reverse this negative processing bias, they actually treat in a chemical way something that's underlying what happens when people are depressed. But they do it in a way that is mimicking the placebo effect, which also works by reversing expectations to make them positive. Is that I hope that's clear. That's my
It makes sense to me, and
okay. It's that's trying to make sense of a very difficult issue, and so in a way that and my two quick proofs of this are one, not every drug that you can give someone that has side effects works as an antidepressant. So it is hard to get a real antidepressant to the market. That's why they're a billion-dollar industry. So if these things were super easy to make, I think we'd have a lot more of them. There are even antidepressants like trazodone that are only partially effective. Well, that's funny. It causes the same side effects, but in every study, it is less effective than the other antidepressants. But the rest of them, serotonin, norepinephrine, and dopamine, all are related to expectations and negative expectations. So it's believable, in fact, that those three kind of chemical pathways would impact and help your expectations to be more positive. And so I think that not every drug works, and the ones that do work are actually working on areas where we think it would make an impact. But the other thing is that they also work in animals, and animals don't really have, as far as I've ever heard, a placebo effect. Maybe there's some crazy studies somewhere that you could do it somehow, but there's no reason, I guess, they couldn't. As long as you're training them what to expect, it'd just be hard to communicate that expectation to them. But you can actually you can treat animal models of depression with antidepressants. And animals do have a negative processing bias when they're in an environment of constant stress. They just do come to expect constant stress. And that does get reversed. So that's why I think it's too much of an argument maybe to say antidepressants are just placebos. But if you really understand depression, you'll see they're working on the same thing placebos work on. They're working on making your expectations more positive. And so the cool thing about that is that's precisely what OptimalWork teaches people to do with reframing. If we're getting people to reframe before every hour of work, at least every golden hour, to deliberately flip their expectations for this coming hour to turn it into something new and better, you're practicing the precise muscle that these things all work on. So reframing is how you get direct control of expectations. So this whole system that placebos and antidepressants can work on, well, reframing gives you the deliberate control over it by allowing you to now more deliberately form positive expectations, even when you had an automatic negative one.
yeah, I always going back to weightlifting. Uh, there would be people who would kind of not want to work out very hard, but instead just take some supplement or some pill that would make them bigger or stronger. So I've always had a hesitancy about like taking something that shortcuts or bypasses the need for real effort or behavior change. So I don't want to be callous in the case of depression, but that's just kind of my mindset coming in. So it seems like reframing is this the behavior change that people need, but taking the antidepressants can help reverse the vicious cycle.
Yeah, exactly. So, what reframing does is when you have an automatic negative interpretation, some negative expectation, reframing allows you to deliberately flip it positive and you experience the effect in real time. It takes some practice to learn how to deeply reframe. So, the more you are getting at the core thing that you're dreading or complaining about and flipping your view of that, the more deeply you feel the reframe. But that is exactly what an antidepressant effect is. It's just the changing of expectations. I think that's the argument here I'm making. I think that it's the best way of making sense of all the data out there. What that would mean is if a person were really depressed, that it would be helpful if you're starting an antidepressant to simultaneously be starting cognitive behavioral therapy to treat the reframing, to get them to practice it. Uh, Even if you just give them cognitive behavioral therapy, it works just as well, even for the most severe depressions. So, medicines have no advantage over cognitive behavioral therapy for treating depression. In fact, CBT has advantages in every single front. So, both in terms of the sense of increased um, efficacy a person has in their own ability to impact their life, their own ability to impact their behavior, in the remission of all the symptoms of depression and, and achieving remission, and then long term staying depression free. But especially in the long term, reframing CBT totally beats antidepressants. So I think of antidepressants as perhaps a brief help that could make it easier for some people to get reframing down, but they're not a replacement for reframing. So if a person takes an antidepressant and is still practicing all the negative habits of complaining and dreading and ruminating, those negative habits could eventually reinstate the negative bias, even in the face of maintaining your antidepressant, and then they get depressed again. It's also why when you're stopping an antidepressant, you want to go very slowly so that in case there's a return of a negative processing bias, you have time to practice the reframing to get back to your normal balance. And then you go down again and you practice reframing enough to get back to your normal balance.
Well, maybe I think the last one I wanted to ask about was ADHD and medicine that helps people focus better and work. That's, I think, very relevant to what we're doing here. And I think there, as we've discussed previously, there's a possibility of getting into a vicious cycle there that impedes your ability to focus in the long term. So maybe you could just talk briefly about how those medications work, and then how that vicious cycle can come into play.
Yeah, I think to give it the fullest treatment, we probably want to dedicate like a whole podcast to it. So I think that what I can briefly say is that what stimulants do is essentially shut off your default mode network. So the background default attention gets turned off by it. That leaves you then with task attention, unimpeded, raw task attention that you can then apply to things without it getting a distraction, which would just be your default mode network trying to intrude on task attention. The problem is that it's not like the default mode network, this default background attention, when it's suggesting the distraction, is trying to be bad, right? Is that it's trying to help. And it just didn't know the right thing, next step to suggest to the person because it hadn't really been trained. So people need to be trained, and their default attention has to be trained in a particular task so that you know exactly what the next step is. That fullest training is called mastery. So you really have mastered the task. Now your default attention just knows how to pull your task attention step by step through it. As you finish one step, it just suggests the right next one. It's a state of training. So rather than with stimulants, it's like instead of just seeing how do I properly train, my background attention to suggest the next step, instead it's just shutting it off. What that leaves then is a deficit of the help that this background attention gives you. And that help is that, let's say you're doing a task and you're simply not sure what the next step is. The purpose of the background attention is to like keeping the end in mind. What are you aiming for? It starts to strategize then steps to get back on track. It's a course corrector so that you're continually getting back to the right path. Without your default attention, there's nothing to course correct if you were on the wrong track and you just go down a rabbit hole with hyperfocus. And that's precisely, I think, what most people's experience is with medicines, that treat the stimulants, I should say, medicines that treat ADHD, is that it can work if you're doing a task, particularly if you know the task well and you know what the next steps are. But it also can lead to rabbit holes and this kind of hyper focus. And it can also lead to irritability and personality changes. It's so in my mind, the real deficit here is the training of the default mode, and putting it to sleep is not the answer. So I don't know. It's like giving the kids Benadryl before you go out in public. So they're just sleeping. It's like it's probably better that the kids learn how to like behave themselves in public and not just be sedated. But that's exactly what in fact stimulants are like for your brain. It's just giving rather than training your default attention so that it helps you and works with you and getting the power of your whole brain working together. It just essentially is turning it off. If not literally turning it off, at least making it so that it doesn't have any way of getting into what's happening in task attention.
Gotcha. Well, Kevin, thanks so much for all these wonderful explanations. Now we're out of time, but I'll give you if you have any final thoughts.
Yeah, I think that in all these things, the danger with medicines is that people might get the idea that unless I have X, there's nothing I can do. And so they become internally reliant on them. And so these things, some medicines, can be helpful. I think there can be a right use of different medicines, but they are never, I, you know, asterisks, except in the case of schizophrenia and bipolar disorder, they're never the only way. They could be an option, but and if people take them, in my experience, the medicine gets all the credit. So, someone's on the medicine, you could do the most stellar anxiety work, and they get better very fast. And then they are like, yeah, I'm so glad I started the med. Like, well, no, millions of people start the med, they don't have this reaction. so, and so it's just when they're taking a medicine, the medicine always takes the credit. And so it undervalues then, or people are led to undervalue the real impact that behavior change has. But reframing, mindfulness, stretching yourself with challenges, that is how you transform the brain from within. And those internal strategies always, I think, are going to pay off more than external ones, even if the external one's taking a med.
Awesome. Thanks so much, Kevin.
Okay, thank you, Sharif.
All right. We'll be back next week.